She Who Awakens by Alina Chamberlain. The Biomechanics of Pelvis Descents. Reconstructing the pelvic floor cradle, ligamentous strain and visceral relocation. To truly comprehend the heights of female orgasmic expression, a woman must possess an unyielding structural foundation. Visceral prolapse, the downward displacement of the vaginal walls or the uterus, stands as one of the most significant mechanical barriers to both pelvic health and sexual pleasure. When internal organs sag, the anatomical angles necessary for friction, neural feedback, and optimal muscular contraction during intimacy are systematically distorted. While clinical interventions offer symptomatic relief, a deep, lasting transformation requires addressing the core physiological and muscular failures that allow the pelvic cradle to drop. Intimate gymnastics reestablishes this core integrity by addressing the true, systemic root causes of structural descents. The pathophysiology of prolapse, why the cradle fails. The primary, global root cause of uterine and vaginal prolapse is the structural weakness of the levator ani, the deep muscle layer of the pelvic floor. The levator ani acts as a living muscular shelf that spans the pelvic floor, sealing the pelvic outlet while leaving narrow fissures for the urethra, vagina, and rectum. In a healthy body, this shelf continuously bears the weight of the pelvic organs. However, our bodies are subjected to an inevitable biological reality. The somatic aging process begins around the age of 25. From this milestone onward, the cellular elasticity and resting tone of our tissues naturally begin to decline. Whether this transition results in premature degradation or is managed with youthful vitality depends entirely on how a woman actively cares for and conditions her physical body. Beyond natural aging, several lifestyle and physiological triggers accelerate the descent of these deep layers under the influence of chronic, descending intra-abdominal pressure. Nutritional and cellular deficiencies. A systemic lack of high-quality dietary protein, the essential building material for muscle tissue, combined with critical deficiencies in vitamin D, magnesium, and B-complex vitamins, leaves muscle fibers thin, brittle, and unable to maintain structural tension. The invisible strain of gestation, pregnancy, and childbirth inflict immense structural changes upon the female body. Even if a woman delivers via cesarean section, her pelvic floor is still subjected to 9 months of bearing the continuously increasing weight of the developing fetus and amniotic fluid. This prolonged stress is exacerbated by high levels of progesterone, a hormone naturally produced during pregnancy to relax smooth and skeletal muscles, preventing uterine contractions but leaving the pelvic floor deeply overstretched. The mechanics of displacement. In an uncompromised state, the non-aroused vaginal canal measures approximately 8 to 10 centimeters in length, and the uterus rests elegantly tilted forward over the bladder. When the levator ani weakens, the vaginal fissure widens significantly. Stripped of its active muscular shelf, the uterus rotates into a strict vertical alignment. Under the influence of gravity and downward pressure, it slides directly into the widened vaginal canal, tracking downward until it presents at or beyond the vaginal opening. Ligamentous strain and visceral fat. The internal organs are protected by a complex ecosystem of internal padding, consisting of a vital fat layer situated between the musculature and the pelvic viscera. Even in slender individuals with a healthy body mass index, this internal fat layer serves as a necessary cushion. When the levator ani stretches and sags, this supportive cushion drops along with it, forcing the secondary support systems, the connective tissue ligaments, such as the wide ligament and the ovarian suspensory ligaments, to bear the raw, unmitigated weight of the descending organs. The visceral displacement cascade. 1. Levator ani atrophies, the primary active muscular shelf collapses. 2. Visceral cushion drops, internal fat padding migrates downward. 3. Ligaments overstretch, connective tissues take full mechanical load and become chronically inflamed. 4. Somatic pain signals, dull aches emerge during prolonged sitting, walking, or deep sexual intercourse. This mechanical shift is the direct cause of the dull, pulling aches many women experience in their lower abdomen. When a woman stands or sits for extended periods, gravity pulls the unmitigated weight of the organs downward, overstretching the sensitive nerve fibers woven through the ligaments. Relief is only felt upon lying down, which instantly decompresses the area. This identical ligamentous pulling causes deep pain during or after sexual intercourse, dyspareunia. Because the uterus is unanchored by proper muscular support, it hangs loosely within the pelvic cavity, shifting awkwardly under the physical impact of intimacy and straining the inflamed ligaments. Managing discomfort during intimate gymnastics. When you begin a professional intimate gymnastics routine, These atrophied muscles and overstretched ligaments are suddenly asked to contract and lift for the first time in years. Just as your calves or glutes ache after a strenuous session at the gym, your pelvic tissues will experience a distinct, unfamiliar soreness. This is a normal physiological response to structural remodeling. If you overexert yourself and experience notable pelvic soreness, do not panic. Simply pause your training, rest completely for 3 to 5 days to allow cellular repair to take place, and then resume your practice with a more mindful approach to intensity. The clinical classifications of prolapse. The exact progression of pelvic organ prolapse is clinically categorized by severity, and it must be monitored accurately. Grades 1 and 2, mild to moderate. The uterus or the vaginal walls have descended into the lower canal, but remain contained entirely within the vaginal vestibule. If a gynecologist notes mild prolapse during an examination but does not specify a grade, it is almost certainly a grade 1 or 2 condition. At this stage, targeted intimate gymnastics is highly effective, offering complete functional restoration. Grade 3, severe prolapse. The uterus or vaginal walls have dropped entirely, presenting outside the body between the labia. At this stage, doctors are clinically required to recommend surgical reconstruction. The surgical fallacy. Surgery can re-anchor and mechanically tighten a descended uterus, but it cannot strengthen the atrophied muscles meant to hold it there. If a woman undergoes surgery without rehabilitating her pelvic floor, the underlying mechanical failure remains unchanged. The repaired tissues will inevitably fail under daily intra-abdominal pressure, leading to an extremely high rate of post-surgical relapse. The surgical absence of organs and accelerated descent. A critical anatomical law governs the female pelvis. The absence of any single organ forces the remaining internal structures to shift. When a woman undergoes a partial or total hysterectomy, or has her ovaries surgically removed, the internal architecture of her pelvis is profoundly altered. Although surgeons meticulously suture the remaining vaginal cuff to the pelvic ligaments, the removal of the uterus leaves an empty space within the lower pelvis. Without the structural presence of the uterus acting as a central anchor, the bladder naturally shifts backward, the rectum migrates forward, and the remaining vaginal vault collapses downward at an accelerated rate. For post-surgical women, intimate gymnastics is a mandatory, lifelong practice. It is the only natural method available to hyperoxygenate the remaining tissues, drive blood flow to the remaining pelvic structures, preserve the health of the bladder and rectum, and halt accelerated prolapse. Clinical adjustments and training adaptations for prolapse. If you have been diagnosed with any stage of uterine or vaginal wall descent, you cannot train like a woman with an intact pelvis. You must strictly alter your technique to ensure safety and maximize structural re-education. Mandatory prolapse modifications. Exclusively supine. Train flat on your back, preferably with a pillow elevating your pelvis above your heart. Total ball exclusion. Eliminate all weighted vaginal balls until structural tone is restored. Diaphragmatic vacuum. Coordinate contractions with an ascending exhalation to lift the organs. Reinforce lower lock. Direct focus toward inward drawing contractions rather than outward pushes. 1. Wall-specific targeting. If you present with a prolapse of the anterior vaginal wall, cystocele, you must place an increased, target-specific focus on isolating the superficial bulbospongiosus muscle to reinforce the anterior wall. If your diagnosis indicates a prolapse of the posterior vaginal wall, rectocele, or a descent of the uterus, your primary training focus must shift to the deep levator ani layer to lift the foundational shelf. 2. The vacuum lift. Every single muscular contraction must be perfectly coordinated with an ascending exhalation. As your respiratory diaphragm lifts, it creates an internal vacuum effect that pulls the internal organs upward. This movement clears the widened levator ani fissure, allowing the muscle fibers to contract cleanly, without the loops of the small intestine or bladder pressing down into the workspace. 3. Inward drawing contractions. You must never perform standard downward squeezes. Your focus must be entirely on executing inward drawing, or retractor contractions, mentally visualizing pulling the vaginal canal up toward your belly button, effectively lifting the organs with each repetition. 4. Eliminating intra-abdominal load and straining. You must strictly avoid any exercise or daily habit that induces straining. If you manage a high body mass index, BMI, you must follow a structured plan to lose excess weight and reduce the constant downward pressure on your pelvis. Conversely, if your BMI is below 19, you must consciously improve your nutrition to rebuild the necessary visceral fat padding and muscle mass. Finally, chronic constipation must be aggressively resolved through proper hydration and dietary adjustments. Forcing an unassisted bowel movement through a weakened levator ani will instantly undo weeks of rehabilitation, pushing your internal organs further down the path of descent. Discover the secrets to nurturing your lifestyle and love style at Wish for Love. The electronic version of all chapters from the full book She Who Awakens by Alina Chamberlain can be found at wishforlove.org.